Hi everyone, my name is Pavel Antiprowicz. I'm a cardiologist and cardiac electrophysiologist in Canada. This is a part 2 of a 2-part deep dive into the diagnosis of wide complex tachycardia. In part 1, we discussed the differential diagnosis of wide complex tachycardia and how to quickly rule out pacing, artifact, and pre-excitation. We discussed the mechanisms of VT and SVT with aberrancy, and in this part we'll put it all together and formulate a strategy to distinguishing VT versus SVT by synthesizing the concepts we just learned. So what tools are available to us? And there are 3 main tools that we can use. The first tool and the best tool is the AV relationship. However, to use this you must find the P waves. The second tool is the initiation and termination. However, this is often not available to us if we're given the middle of the tachycardia. And lastly, there's Qrs Morphology, which is probably the worst of the 3 because it's largely probabilistic of how confident are you that the Qrs Morphology matches a bundle branch block. Let's take a moment to go through a few hints to find the P waves. Oftentimes wide complex tachycardias are quite wide and fast, and it's very hard to see small P waves within it. The first hint is to look at the lead with the smallest QRS, because the smallest QRS gives you the biggest chance of finding the P wave. The second hint is to look outside the bounds of the QRS. What I do is I put a vertical line down all the simultaneous leads to find the earliest part of the QRS and the latest part of the QRS. And you can only call P waves outside of the bounds of the QRS, because the QRS represents depolarization, just like the P wave is an atrial depolarization. And any part of the QRS can always look like a P wave. So never call a P wave within the bounds of the QRS. And finally, it's important to template. So in this particular example, you have a sinus QRS and you see this T wave. And here you can see a high frequency deflection within this T wave, which is almost certainly a P wave. And remember, it is okay not to find any convincing P waves on a tracing. It just means you can't use the strongest tool in your toolbox, which is the AV relationship. But you can use other tools available to you and just move on. Now let's dive a little bit deeper into the AV relationship. Remember that some VTs can retroconduct to the atria, and some have VA block and are unable to conduct to the atria, which leaves atria with sinus rhythm. This is AV dissociation. If you see AV dissociation with more V's than A's, then this is diagnostic for VT. If there is VA conduction and you see an occasional dropped P waves or VA block, then it is also diagnostic for VT. However, if you see more A's than V's, then the V's must be driven by the A's, which points to SVT with aberrancy. Another helpful and somewhat sophisticated tool is Wobble. If you have variability in the rate, you can see which moves first. If the A's move first and lead the V's, that means the V's are driven by the A's and SVT is diagnosed. If the V's move first, then it could technically be either, but for the most part it would be compatible with VT. Let's use the tools that we learned on this example. This is a wide complex tachycardia which has the usual differential of VT, SVT with aberrancy, pre-excitation, pacing, and artifact. I don't see any pacing spikes, and this is a very clean tracing, so we can exclude those 2 possibilities, and this does not look like a usual pre-excitation pattern, although we don't have a baseline ECG. So we're down to VT and SVT with aberrancy. If you look very closely, you can see the P waves on this tracing, and you're welcome to pause the video to find them yourself, but I will mark them here. As you can see, you can map the P waves, map the sinus rhythm all the way through the tracing. So there's more V's than A's, there's AV dissociation, so this has to be VT. So this is an example of a VT that cannot retroconduct to the A. And then there's an ambient sinus rhythm in the atria, which is the definition of AV dissociation. We've already went through this example, but just to remind you, this is an example of a wide complex tachycardia with a 1-to-1 AV relationship. But there is an occasional block to the A. There is A missing. So there's more V's than A's. This is diagnostic for VT. Now let's look at our second tool, the initiation and termination. The initiation and termination of tachycardias is very powerful and very helpful diagnostically. Oftentimes, as a consulting service, we're giving ECGs that show the middle of the recording, and by not recording the initiation or termination, we're missing a very powerful tool available to us. As a general rule, VT does not initiate with an atrial activation. In this example, we see a wide complex tachycardia. The very first event of this tachycardia is this P wave. It's a PAC. So this PAC initiates the tachycardia, which means that it is almost certainly SVT. And this patient likely has wide QRS due to a rate-related bundle branch block. Some experts may say, well, some VTs can initiate with an A, such as bundle branch reentry VT, but this is extremely rare. Initiation with a V is less helpful, but we generally say it's compatible with VT. Now, there are some SVTs that can initiate with a V, but probabilistically, this will be VT. In terms of termination, this particular tachycardia terminates with a V, because I can clearly see P waves after each QRS, so it's a 1-to-1 VA tachycardia, and the last one is missing. So let's play out the VT in this scenario and see if it's compatible. So for this to be VT, these A's would have to be retroconducted in a 1-to-1 fashion. And in the last cycle, the VT would have to stop, whatever mechanism in the ventricle that's causing the VT would have to terminate, and the last beat of VT would also have to block in the AV node and not conduct to the atria. So the VT focus and the AV node are separate structures. And what are the chances that both of these unrelated events would happen at the same time, on the same cycle? Therefore, termination with a V, when you can clearly see a 1-to-1 VA tachycardia, is supportive of SVT, especially if you see this happening more than once. Now, termination with an A would generally be compatible with SVT and VT. For those who are interested, it only rules out AT. However, we generally say termination with an A is compatible with VT, and for the most part, probabilistically, this will be VT. In this particular example, we see a wide complex tachycardia, which has the usual differential, and we see that the first event of this tachycardia is a V. We don't see an atrial activation before this. So we say this is the wide complex tachycardia that initiates with a V, which has a 1-to-1 VA relationship, okay, which is not that helpful, but generally compatible with VT. And we see that the last beat is an A. So it terminates on an A, which is compatible with VT. So this will almost certainly be VT. This is another example where we see sinus rhythm, which are the first two beats, and then we see a wide complex tachycardia. And I'm looking at this T wave, and I'm looking at this T wave here and comparing the two, and I see that there's a high frequency deflection right here that's almost certainly a P wave. And it's an early P wave, so that's the first event of the tachycardia. So I see that this wide complex tachycardia initiates with an A. Okay, so this is supportive of SVT. And I see that it ends on a V, okay, without an A. So this is compatible with an SVT, and almost certainly is SVT. And the third reason is that I see this QRS complex is a right bundle branch block morphology, and it's almost identical to the sinus QRS complex. So all these features would make me fairly certain that this is SVT with a right bundle branch block. This particular tracing also demonstrates a very important tool, which is cycle length variability. Whenever you see variability in a tachycardia, it gives you the opportunity to evaluate the intervals to see whether A's are leading the V's or V's are leading the A's. So let's take a closer look. So when we measure out cycle lengths, we can see that whenever an AA interval shortens, the VV interval shortens after it to match it. so that when the A moves, the V follows. So the atria are driving the ventricles. This is compatible with an SVT. Also note that if the opposite is true, if the V's are leading the A's, this will be consistent with VT, although there are SVT mechanisms that this can be explained by. Finally, let's take a look at the last tool we have in our toolbox, which is Qrs Morphology. Now, Qrs Morphology requires you to identify a left bundle or a right bundle branch block in a wide complex tachycardia, and it relies on your ability to distinguish a good from a not so good bundle branch block, and this is mostly probabilistic. So this is why this is the weakest tool in this toolbox. And often an important clue is the baseline ECG to see if the baseline ECG has a bundle branch block which looks similar enough to the QRS in the tachycardia. And it is very commonly that we get an ECG where we can't see any reliable P waves, and we don't have the initiation or the termination of this tachycardia, so we can't use that tool either. So the only tool we have is Qrs Morphology. Let's take a look at the Qrs Morphology and how we can use that to distinguish VT from SVT with aberrancy. To use Qrs Morphology, you have to know what a bundle branch block looks like. So when you look at a wide complex tachycardia, you can decide how good of a bundle branch block it is, rather how convincing it is. So let's take a look at a couple of features. When I was a trainee, I would actually take a blank sheet of paper and take a picture of a left and right bundle branch block on a 12-lead ECG and draw out the appearance of the QRS in every lead on a blank sheet of paper. And I would do it until I'm able to produce it from memory. This helped familiarize myself with what a bundle branch block looks like. So I'm going to take you through a few pointers. First, it's important to note that getting a baseline ECG is very important, because if the patient has baseline bundle branch block, that can be quite helpful and raise the suspicion that this is the same bundle branch block, just accelerated. Okay, but it's also equally important to note that when the ECG accelerates, the QRS can change somewhat. So it has to be a fairly convincing match between the baseline QRS to the QRS in a tachycardia for me to be fairly convinced that this is not VT. Okay, it has to be very convincing. Okay, so let's take a look at a couple of features of bundle branch block that can be helpful. So let's first take a look at a right bundle branch block. So in V1, the right bundle branch block should look like an R, S, R prime pattern. Okay, so the first positive deflection of the QRS is always an R, no matter how small it is. Even the tiniest positive deflection initially is an R. The first negative deflection is an S, and the second positive deflection is an R prime. Okay, so this is an R, S, R prime in V1. Now let's take a look at the bundle branch block in the lateral leads in 1, AVL, and V6. So for those who aren't familiar looking at bundle branch blocks in the limb leads, this can be quite helpful, because oftentimes you don't have the precordial leads and you can just use the limb leads. So as you can see, the first part of the QRS looks fairly normal. Okay, it's got this it's got this Q wave, which denotes left to right septal activation. It's got a nice narrow part of the QRS, and it's got this very slow, slurred, shallow S wave. So the shallow S wave is the part that tells me that this is probably a right bundle branch block. This is the RV myocardium that's slowly activating dysynchronously in a cell-to-cell fashion. Okay, and the reason why the first part of the QRS looks identical in every lead to a normal narrow QRS is what I'll describe in the next slide. If there's a right bundle branch block, there's no conduction down the right bundle. It's important to note that the first part of the QRS is actually septal activation. Okay, the first little Q in a QRS is actually quite normal, and you can see it in a lot of the lateral leads. This represents a left to right septal activation, which takes place via the left bundle.
So there's some signal that exits and activates the septum in a left to right fashion. Okay, that's why when you have a right bundle branch block, the first part of the QRS actually looks the same as a narrow QRS because the septum's activating normally and the left bundle is able to quickly activate the majority of the muscle, which is the left ventricle. And when you have the left bundle branch block, it's completely the opposite. In this conduction down the right bundle, the septal activation is now completely reversed, so you lose that little Q wave in the lateral leads. The septal activation is inverted, and the LV, which is the bulk of the muscle in the heart, is activated desynchronously in a cell-to-cell fashion. This produces a very large amplitude, very slurred, very wide QRS, which we see in the left bundle branch blocks. And understanding this physiology is quite helpful when you look at Holters, because when I look at a Holter and the QRS looks wide, if I see the first part of the QRS match the narrow QRS, I'm thinking this is probably a right bundle branch block that comes and goes. Okay, so now let's look at a left bundle branch block. We mentioned that if there's a left bundle branch block, the QRS looks completely different than the narrow QRS. In V1, there's often a little R, and there's a very large negative S wave. Okay, and in the lateral leads, 1AVL V6, the Q wave that we saw in a normal QRS or in a right bundle branch block is gone. Okay, because the septal activation is inverted right to left, and there's a very positive, large, slurred or notched R wave. It often has this notch or a slur at the very top. This is very common and very typical of a left bundle branch block. The other feature that I wanted to point out is the fast onset. Okay, so whenever there's a bundle branch block, there is often a functioning contralateral bundle. Otherwise, this patient would have a complete heart block. So the first part of the QRS is still often quite sharp. Okay, and this represents this is consistent with a bundle branch block. Whereas if you have VT that doesn't have very good access to the conduction system, the first part of the QRS is often quite slurred, and you look at it and say, well, this doesn't look like a bundle branch block because look how slurred it is. The first part of the QRS is not activating quickly by any bundle. It's probably cell-to-cell activation. So this would make me think more VT. Okay. There's also certain features that are not consistent with a bundle branch block, which we'll discuss next. For example, in a right bundle branch block, the first R is always smaller in amplitude than the R prime. Okay. If this relationship is reversed, the first R is larger than the R prime, this is very atypical for a right bundle branch block, and we're thinking more VT. These QRS morphology features that I described are just natural physiology. That's how a bundle branch block normally looks. The initial part's very fast, and there's certain typical features that we look for. So the criteria that were developed, such as the R wave peak time in lead 2 and Brugada criteria, actually look at these features to find which features are typical of a bundle branch block and which aren't. So in this particular criteria, R wave peak time criteria, they look at from the onset of the R wave to the peak of the R wave and the time it takes for the QRS to reach that. Okay, so this is the initial QRS activation time. And obviously, if it's very long, this is not usual of a bundle branch block because, as if you recall, a bundle branch block has a functioning contralateral bundle. So the initial part of the QRS will be activated by a very fast His-Purkinje system, so it would never be this slurred like that. So if there's a big slur at the beginning of the QRS, it's generally compatible with VT. And they did a study which shows that if it's slurred by more than 50 milliseconds, it's very good for VT. And if you look at Brugada criteria, this is one of the first published criteria. He actually looked at different features of the QRS that are typical or atypical for a bundle branch block. And a lot of these features we kind of went over. So, for example, if you recall, in a right bundle branch block, if the first R is larger than R prime, and it's very unusual, it's almost certainly VT. And in a left bundle branch block type morphology, QRS, if there is a notch on the downstroke of the QRS, remember we mentioned the first part should be nice and smooth and fast. If there's a notch on the downstroke of the QRS, that's very unusual for a left bundle branch block, and it's generally considered to be VT. Let's try this ECG as an example. This is a wide complex tachycardia which has the usual differential of VT, SVT with aberrancy, pre-excitation, and pacing. I don't see any pacing spikes. This is a very clean tracing. I don't see any noise, and this is very unusual for a pre-excitation, although we don't have a baseline ECG. And as you can see here, I don't see any clear P waves. However, and I don't see any termination or initiation of the tachycardia. So we're really stuck with the morphology, and as you can see, it has an R, an RS, R prime morphology, where the first R is tiny and the second R is much larger, which is typical of a right bundle branch block. And as you can see, the first part of the QRS is very fast onset, and it's got this slow, shallow S wave here. This is very typical for a right bundle branch block. So I would say, generally we would start any ECG with saying this is probably 80% VT, but seeing these features would definitely make me question the VT diagnosis. It's QRS morphology is never absolute. I can't say with 100% certainty this is SVT because QRS morphology is probabilistic. However, it makes me somewhat question whether it is VT or not when we're managing this patient. But certainly I would manage them, especially if they're unstable, as a VT. However, if I look very closely, you could see that there is some activity in lead 2, which is the lead with a very small QRS, with the smallest QRS actually, which is the best place to find P waves. There is some activity here that's very sharp in between the two QRSs. So atrial activation is a depolarization. Depolarization is generally sharp. T waves are repolarization. Repolarization is smooth. Okay, so these are sharp waves that are in between, outside the bounds of the QRS, and I see two little waves here that are about rate 300. So this makes me think this is probably flutter, and certainly, and there's more A's than V's. Okay, this is compatible with some sort of SVT, which in this case is probably flutter, and certainly with the Qrs criteria also pushes me towards SVT. So I would say this is probably flutter with a right bundle branch block. And certainly this patient was very stable. We gave him adenosine, and it ended up being flutter with a right bundle branch block. This is an example of another wide complex tachycardia, which has the usual differential. And this is the one where I'm not as confident with the P waves. There are some sharper deflections here. If I put a straight line across this QRS complex across all the leads here, it's probably outside the bounds of the QRS. I would call it a candidate P wave, but if you're not quite sure, you can just leave it as a candidate P wave. But certainly looking at the QRS morphology here, it's very slurred. Like, look at this slur here. This looks nothing like a bundle branch block. Like, bundle branch blocks often start off very fast, very sharp, activating due to the functioning bundle. So there's no way this is any sort of bundle branch block. This is almost certainly VT. And this is the last example of this session. In this particular case, this is a wide complex tachycardia, has the usual differential diagnosis list. And if we're down to VT and SVT with aberrancy, I can't see any P waves here. This is so I can't use any AV association criteria or dissociation criteria, and I don't have initiation or termination. So we're really stuck with Qrs morphology, which, as you know, is probabilistic. And looking at this is a left bundle type of QRS. Looking at V1, it's negative. There's a little R prime, which is compatible with it. However, if you look at the rest of the leads, they're all negative across the precordial leads. So bundle branch blocks, I generally never have this uniphasic QS leads everywhere in all the precordial leads. So this is very unusual for a left bundle branch block. So by morphology alone, it will be consistent with VT, and this reinforces the probability that this is very likely VT. Now, just a note here, if there was no little R prime here, this would generally be called concordance. And if for those of you who know the Brugada Criteria, the first step is there concordance, right? So if they're all QS complexes like that with no positive deflection, they're all negative, one single complex, and there's no positivity at all, or if it's the opposite, if they're all positive with no negativity at all, we would call this concordance, and this is very specific for VT. Really, it's just describing normal bundle branch physiology. There is no bundle branch block morphology that looks all positive with no negativity in precordial leads, or all negative with no negativity in the precordial leads. Like, it's just a morphology that's also very rare. Like, it's extremely rare that you'll find a VT which was completely negative that looks like this, very unusual looking. It was put in a Brugada criteria, but if you look at this does not look like a bundle branch block at all. So this is almost certainly VT by Qrs Morphology criteria. So that brings our session to a close. To summarize, the first step is to identify that this is a wide complex tachycardia, and certainly if the QRS width is greater than 120 milliseconds or 3 little boxes, it's considered wide, and it has the usual 5 differentials, and then you can narrow the differential diagnosis further, and once you're down to VT and SVT with aberrancy, you can use the tools that we learned here to help narrow it further. And again, if you're not sure what the diagnosis is, one way or the other, it's always safer to presume that it's VT and treat it as such than the other way around. So if you're in an exam or something, it's often it's safer to treat it as VT. And so using these tools, you'll be thinking like a real arrhythmia expert, and because you'll be using your core understanding of arrhythmia principles to help solve these problems. And I'll be posting some practice ECGs shortly so you can practice these tools. And I want to thank you for your attention and have a great day.